staff internally at the state. So those on the New Choices waiver team, if you guys just want to introduce yourself, wave, say hi, say your name, and we'll just go around the team. Vicki, do you want to start us off?
Yes, I'm Vicki Rouge, and hi. I think I've been here forever, so most people.
Everybody knows Vicki. Yeah.
I'm Jen. Hi.
I'm Blake. Hello.
I'm Krista. Hi.
Hi, I'm Amelia.
Hi, I'm Marisol. I'm the nurse for the program.
Hi, I'm Troy Knutson. I'm the newest person on the team.
Yeah. Thanks, Troy. Troy comes to us from Washington, has some great experience in the long-term services and supports world. So he's a new addition to the team. We also have, I believe Joseph and Matt might be on the call. If you guys are here, say hi.
Good morning. Hi, everybody.
So Joseph's going to be humble and not tell you all this, but he is now our new Bureau Director. And Matt Lund is the Assistant Bureau Director. I don't know if Matt, if you're available to say hi. Maybe not. I hope he'll be joining us in a few minutes, or maybe he's stuck on mute. That tends to happen to a lot of us. We think we're talking and can't get off mute fast enough. We also have some guests here with us, which I will introduce in just a minute. But to go over kind of some housekeeping items and purpose of this forum, we elicited feedback a while ago, wondering what training topics were of high priority and importance to you all. And overwhelmingly, Appendix K policy changes were the hot item. So that is what we are regrouping today to go over. Any questions that you have, we'll do a similar format that we did last time, where we'll ask that you submit questions in the chat. And then I will have some of my colleagues working behind the scenes to help put your questions up for me, and we will just go through them one by one. So before we get to the long, awkward pause that we did last time, start thinking about your questions. And if you've got a chance to take a head start and put them in the chat, that would be helpful as we're going through kind of our housekeeping items. So more than anything, the goal of meeting today is to offer you guys support and to learn what items are challenging for you all. As we create policy and procedures, we want to work together and act as a team here, because we very much have the same common goal. So more logistics, we are going to keep everyone on mute to make sure that we don't have any background interference. Questions, please submit them in the chat. We will be staffing that. In the top right corner, you'll find the chat icon, and it will open a larger panel, and you can enter the question in the bottom of the screen and click the green arrow to send. Please note that messages will be visible to all participants, so we'll be able to see. I don't know if you've been a victim of that. I have, where I thought I was sending a private message and it wasn't, but luckily it was nothing too embarrassing or incriminating. I think by now everyone knows how to disable and enable your camera. If you encounter technical difficulties, just reach out to us through the chat function. We'll have someone manning that and looking out for things like that. Today's meeting is being recorded, and we will be sharing the meeting afterward, so that if there are items that you'd like to share with your team, since we have, it seems like, just the key representatives from the agencies, you'll be able to share this among your group. We will do our best to answer all of your questions. Like last time, there may be some that we can't get to, but we will follow up afterward. And we slated this meeting to end at 11:30, wanting to add a little bit of a buffer. If we conclude before then we will let you go a little early, but we will take advantage of this time and then end promptly where we can. So as far as the COVID policy guidance, the document to reference with any questions that you may have is the New Choices Waiver Provider Guide, which was last updated at the end of January 2021. So diving in with our special guests, I'm really grateful that these gentlemen were able to join us. A lot of the questions that you guys submitted in advance had to do with Medicaid eligibility policy and DWS procedures with eligibility reviews and what's going on and when are things happening and when is normal going to resume. So we have some guests here who can speak to that as much as we know. We don't have all of the answers. So I'll do some introductions and you guys can say hi. Jeff Dart is representing Medicaid eligibility policy. Jeff, if you want to say hello.
Hello, thanks for having me.
Yeah, thanks for joining us. And then we've got Nate Palmer and Alan Dickinson, who are representatives with Department of Workforce Services, who you guys as case managers coordinate with a lot. So if you guys want to jump on and say hi, that would be great.
Good morning, folks. Good to see you all. A lot of familiar faces here and names, so happy to be here.
Thanks, Nate.
Hi, thanks for having me. I'm kind of newish to the long-term care business. I've been here for about a year now, supervising one of the teams. So I'm probably learning a lot here too. So thanks for having me.
Thanks, Alan. I think one thing that we've learned along this journey really is that we're all learning as we go, and sometimes I don't want to say making up the answers as we go, but we are coming up with solutions as we go, because we've never been in this situation before. We've been here for a year, so we've gotten a little bit more comfortable with what's occurring. But I think we've all got a pretty good sense of patience for each other at this point and working as a team, which I really appreciate. Okay, so just jumping right in, if you guys want to submit your questions on the DWS and Medicaid eligibility policy side. We'll take any and all questions in the chat, but we'll start with that topic since we've got these three gentlemen here and available to ask or answer questions. So while you're doing that, we can start off with the questions we had already received. The first one was surrounding the idea of what would happen if a spend down is not paid. Would DWS close the case? And if so, when? And Jeff and Nate and Alan, I'm not sure if you guys have any more recent guidance than what we gave out to the case managers, which was, if this happens, call us and we will staff the case. And really that would just be a case-by-case scenario. I think there's agreement across the board that we wouldn't want to close someone's case for not paying a spend down if it had to do with abuse, neglect, or exploitation, or if there was a solution that could be seen. But do you gentlemen want to chime in? Any recent guidance available there?
Yeah, I can try to help a little bit here. Beginning in December, I guess for January benefits and going forward, CMS has changed their guidance a little, and we are allowed to make changes to a program a customer may be eligible for. We still cannot close their eligibility, but we are allowed to move them if appropriate and if applicable. So if there is a spend down not being paid and it seems appropriate, we could move them and look at like an ABD program. They would remain eligible in our system. We currently would not be closing them for anything, but we could potentially on the eligibility side look at a different program under the Medicaid umbrella. Part of that has been a discussion, and I don't know if a decision has been made about whether we'd want to disenroll eligible people. And Lainey, maybe if you have any further information on that, a disenrollment on the Department of Health side would then for sure make the waiver program close on the eligibility side, and they'd be looking at ABD most likely, but some Medicaid program to keep that client open, because we cannot in a public health emergency close them. Even though the guidance has changed, we could look at circumstance and possibly move them. We will not be closing any programs.
Okay.
Clients that are eligible would remain eligible somewhere under the eligibility umbrella.
I think that's helpful for us to know, because there have been a handful of cases that have come up where someone has been refusing or uncooperative for whatever reason with paying their spend down. And that puts providers in a situation where they may not be able to bill. And then what do we do with them at that point? So that's where we're asking the case managers to reach out to us, and we will address that on a case-by-case basis. Because, you know, if it's a scenario of abuse, neglect, exploitation, we would handle that differently than someone who just is not going to pay it, understands the situation. Then at that point, I think we would look at disenrolling them, because we don't want to compromise our provider pool by having our providers not be paid for the services that they're rendering. So that's where we'd probably work closely with the DWS folks. So that's good for us to establish that in this setting. That's helpful. Okay, another question that has come up is, how long will someone have to spend down their assets that have accrued as a result of being in a nursing facility, but still on waiver Medicaid, to where they're not paying a spend down or a share of cost to the nursing home? I think there's concern of, you know, what do we do with their money? What should it be spent on? What can it be spent on? And how long of a grace period is someone going to have before their benefits are just cut off? Can you guys speak to what we know about that?
That's a great question. And with the emergency, we've seen cases that have gone over assets and obviously not paying their share of cost in a nursing home because they're on the waiver and they do get to keep that. What we've in the past, we've indicated to clients to maintain their room and board agreement with the assisted living facility, especially if they're going to go back within 30 days or something, you know, keep paying their responsibility in the community to hold their spot. If specifically they know they're not going to return to the assisted living center, then that's when you as a New Choices would consider disenrolling them and saying, okay, they're not going to fit that level of care, or they're not returning back to that setting. So we can get them open on nursing home and make that correct change, so their income is going towards their skilled nursing facility cost of care. And how long is a good question? Like, how long is this emergency going to go on? How long are we not going to shut people down? The best response I have to that is get those assets down as soon as possible. And specifically, there's that temptation to say, well, you know, I've got this money, I need to help my family during this time. But really, transfer of asset policy is in force, and clients who are in an institutional stay or in a nursing home do need to use their resources for themselves. And so appropriate things is just to use it for themselves, purchase funeral plans, purchase items that they need, really, again, for themselves. if they go over assets and the pandemic ends, it's not the end of the world for this client, especially if they have enough resources to pay privately for a couple months and get back on in the system. Medicaid eligibility is designed to reopen quickly when someone is, been denied for assets. It's pretty easy for an eligibility worker to, shut a case down for 2 months due to over assets, and then person reapplies and get going again. So I wouldn't let assets be the reason or a fear to say, well, we can't, we have to keep them on waiver or whatever. Obviously it's easier, but when this pandemic is over, and we'll speak to that in a second, most of these cases are going to have to be reviewed very, very deeply, a deep review, and it's not going to be a problem to verify assets again. Most of them are going to be requested to verify assets just because we've been pushing a lot of things to keep open.
I think something we have seen as a pattern in the past is waiver cases will close for being over asset, and the case managers find out about it, a month or two down the road. And then at that point, they're looking at a situation where they're not able to be paid for the services they've provided during that period of time. They weren't aware that it had closed. And, there is an expectation that providers verify eligibility every month. Is there something that case managers should be doing to verify that they will be contacted with those updates as the representative on file?
So you're indicating that there's a lot of times the case is closed on DWS's side and providers are not aware 2 months down the road that they're now ineligible. Is that what you're indicating?
Yeah.
Is it mostly tied to reviews, or is this tied to, this is outside the pandemic?
This is even out in normal times.
Mm-hmm.
Yeah. So I think the pandemic is just heightening this concern, where previously we understood that we needed to keep care plans open and people on waiver Medicaid, even in SNFs. So now that has changed, we'll be submitting disenrollments, and that won't be a problem. There's another question there that I have that I'll want to follow up on, but even in normal times, we run into this issue. So we are worried that we will run into a mass issue now.
Your worry is definitely our worry too, with the way cases are being kept open, and we're not sure with where people are really at with their eligibility. And this ties into the next question, is when are we going to start doing reviews again? Reviews are still being held. If a client doesn't provide their review, or they don't turn in a review, that review just continues to be pushed each month with a due process. And so it matches the prior month review. It's just a mirror image of reprocessing each of those months. So the best thing to do is complete the review, even if they're over assets, even if they're during this time, we'll keep them open. And then what we have on there is we complete the review, get them a new certification for whatever we're doing for the next 6 months, and right now our thing is push things out to the next 6 months or the next review, whichever's closer, with pushing effective dates on over assets or things not verified. But so it comes back to that review should be completed. You should go through every process to try to be as complete as you can, so that worker doesn't have any reason to say, I'm questioning this case when the pandemic is over. It just makes it really easy. And so that's one thing you can guarantee, is help DWS to say, hey, this case is clean. They've got the review completed. They've everything taken care of. It's above par. So it maintains once the emergency is over. We're not touching that case with all the other cases that we've done to keep open.
Okay. Do you have, I know this is kind of putting you on the spot, but I think it's an opportune time to address it. Do you have a sense of whether or not, as a group, we need to verify that reviews have happened or follow up on ones that need follow up? Like, is there catch-up work that you recommend that case managers do at this point to make sure that someone's in good standing, or what does that look like?
That's a great question. The more, and this is what we tell our workers, the more effort you put in now is going to pay out in the end. Because really what's happened is this: we've had a whole year of eligibility that we haven't acted on negative decisions.
Mm-hmm.
So it gets really kind of scary when you think about the implications of what every case needs to be looked like. So we tell eligibility workers the most that you can do to keep cases correct, complete the reviews when they need to be completed, make sure assets are verified. Then you don't have to touch that case. You don't have to retouch it. And that's the same way you're on the other side of that caseworker doing the same work. If you could verify they're under assets, their review's complete, that's one you can check on your list that's not going to hit the radar when COVID ends, because it's consistent and it's in there. You're going to have confidence that that's going to be a 12-month certification from that review. Just like any other, does that make sense? So yeah,
I think so.
If you want to put the effort into verifying each of your cases that are questionable, I would say do it, because it's gonna help us and it's gonna help you when the emergency ends.
Okay.
So yeah, and adding on that a little bit, Nate really addressed it, but any case that is cleared and the review's processed and we're in a good place when the public health emergency ends won't need to be touched as soon as it ends. We have a wind down panic problem, kind of. Like, there's so many of these cases that there could be negative action. We can even see that, but we're not taking that. That as soon as the public health emergency ends, the next month may hit ineligible. Those that haven't had a review processed will also end up in that pool that we need to get a review as quickly as possible. But if we can do a review in its normal time frames, even though it may not be necessary to keep the program open, it will at that moment help, because it won't be pushed to a front of the line. When the public health emergency ends, it won't necessarily need to be looked at until its normal review period next time. So any of those cases that we can keep rolling as clearly as possible. Also, potentially, if we do a review and see something concerning, it may give a heads up of something to try to address before the public health emergency ends. If there is assets that are building up, you can see that and then look at funeral plans or any of those expenses before the public health emergency ends to make sure that they remain eligible when that becomes required again.
That's helpful. So it's probably a fair statement to say that our advice at this point is to be proactive. So it would be in everyone's best interest if a case manager kind of took stock of their caseload and made note of reviews that they've recently assisted with or verify with their family member or whoever is helping them with their Medicaid case that the review has been completed, there's nothing else needed, and then follow up on those that do need the review completed so that we're not caught in this scenario of, oh no, what do we do? We're not going to get paid, but this individual still needs services and can't pay for it. So that's really helpful. Thanks for that guidance there. Let's see, the next question. Oh, before we move on to that, part 2 of the question I asked earlier, you touched on asset reviews being completed. And I am not familiar with this process, so this may be a dumb question. But when we do start submitting disenrollments for individuals who have been in the nursing home for at least 90 days, that should already be occurring, but we imagine that we'll have some people who've been in a nursing home for a year. Will they have an asset review at the time they're switching from waiver Medicaid to nursing home Medicaid? And will that then cause some concern for what their assets look like?
No, no. Well, they will have an asset review in the sense of if they've been on New Choices waiver, the worker at the DWS is going to say, we're switching you to now, you've been disenrolled now from New Choices. We're making you into the nursing home program and you're starting a cost of care next month. We do need to verify assets at that point. If the client doesn't provide verification, we're still, during the pandemic, going to make change to nursing home.
Okay.
And we'll put a little tag on there that says verify assets at the end of the pandemic. And and so we keep them open just like all programs, but it's going to be, those assets will have to be addressed.
So at that point, it becomes the facility's their best interest to manage proactively their eligibility and any follow-up necessary. Okay.
Correct.
That's helpful to know that we're not putting people in a bind either way. Okay, so next question. With a review not completed, do they continue to allow our clients to not have their case closed with the COVID emergency?
Yes.
Sounds like we've kind of already answered that one.
Yeah, it's
right?
just, and that's the interesting thing with waivers, and they have a cost of care. If they don't, even though we keep them open on our end, and they haven't made the spend down, there's no benefits issued still. It's
Okay.
just, and that's the weird part about waiver and keeping a case open. They still have to meet their spend down, but yes, we do push that review each month and give them what we call a due process month, a mirror of the prior month.
Okay, great. Next question is, do individuals still need to spend last year's stimulus check by March 2021?
Go for it, Jeff.
Well, that's.
Is this a sensitive topic?
Well, no, it's just a tough answer. Policy says yes. The world where we can't close them says that that's not something that's going to get a ton of action on if not. Like, so from a policy perspective, yes. From a public health emergency perspective, we're not going to take that negative action if they don't.
But still probably something that's in their best interest to be proactive about and monitor assets.
Right. And I think, Lainey, you're catching on pretty well. What our best advice is from an eligibility policy and from DWS is try as much as possible to treat this as you normally would with cases. It's tempting to say there's a public health emergency and they're not going to close anything. So, but on the back end, it's going to be messy for all of us if cases aren't caught up. It could be messy for our clients if we were aware of things we could have helped with and didn't, just because we know that they're not closing. So the best practice answer for pretty much everything is we just keep going as if there's not a public health emergency.
I agree. Okay. That's helpful. Next question. We try to use the eligibility lookup tool, but we've had difficulties using the tool to verify a client eligibility. I don't know if we're doing something wrong or question mark. Have we heard any issues with the lookup tool? Is it just something, or maybe something that we need to provide guidance on from our end?
I am not aware of any issues. I haven't heard anything, but that doesn't mean it's not possible.
Okay.
But I don't know if you want to look at this issue a little bit, Lainey, and try to provide them some guidance. And then if you see an example, if you know what maybe we're looking for, you can send it to me and we'll at least track it down.
Okay, that sounds like the appropriate strategy or case by case scenario. You know, Medicaid eligibility is checked at medicaid.utah.gov or by calling 801-538-6155. But we can work through some guidance and any technical difficulties.
And last resort is the eligibility worker too. You can call them and talk
and
to
just
them.
make sure. Okay. All right. These are great questions, you guys. Thanks for the participation and the really great answers. So next question, how can a case manager make sure that, I'm assuming the DWS long-term care eligibility workers have our contact info or address so we do get the notices? We have clients who have set up My Case, so all notices only go to the email set up on the My Case site. Other clients, we just do not get notices, and it only goes to the client. We often find that clients fail to tell us about the notice, and we do not realize that there is a problem until we check eligibility.
That's a great question, and it's something that's plagued us from the beginning when we work with providers, especially, and authorized representatives. EREP is not designed to be really provider friendly. It's household friendly. It's individual friendly, especially with My Case and those type of things. So on specific cases, I would say that we really need to track this down for you. My understanding of the system, and I've been doing this for quite a while, is that even though the client has selected My Case notices that go electronic, representative notices like second party notices such as reviews, that stuff, will still be mailed out to an authorized representative. So first and foremost, let's make sure your 114 AR or the authorization to release information is up to date with that specific case. And you can do that by just making sure you fill out a new one. That's if you're having problems with specific cases. I know that's a cheesy answer, but it's really a great way to make sure that you're authorized. Number two, you have the correct box checked. And a 114 AR, there's two boxes. I could share a form with you right now if you wanted to see it, but
Sure.
One just says speak or act in my behalf. I'll pull that up real quick so we can just share this.
Okay, great.
And the other one is, speak or act in my behalf or just get information. The first one's just get information. The next one's speak or act in my behalf. And sorry, pulling up here. You want to make sure you select the bottom box if you're going to act for the client in regards to help them obtain eligibility, do that purpose. If you just want information, the top box is fine, but you need to make sure that you fill out the 114 correctly. Okay, I'm just getting here.
And Nate is correct. In a previous life, I worked at EREP, and so I know a little bit about this. But even if they have a My Case account and get all their correspondence on My Case, as long as we have a correct authorized rep set up, we still should mail those authorized reps the notices as well. So we make it electronic to a customer and still put it in the mail to whoever else on the case is supposed to receive the correspondence. So hypothetically, if they're not getting it, the first place to check is make sure that the authorized rep status on that eligibility case is set up correctly, the form's in and right, and then that it was entered correct on the eligibility side if the form's in and correct.
Correct. Thank you, Jeff. So Here we are looking at the 114 AR. Really, the customer's name here gives the organization, whichever case management agency you are, the authority to act. This is where we have a little bit of confusion. You only get to check one box here. The first is receive Medicaid or buyout eligibility information regarding my current application, ongoing case, or a recent denial. The authorization is effective from the date it's signed, or to the following, or whichever the following occurs first. So they check a specific date through the end of the application cycle when it's denied, or 30 days from a closure. So what happens is, if you just select that in your name of the organizations here, that's great. No worker is going to send you notification of anything because they don't have your address. If you say check box 2 down here, and I say speak or act in my behalf, get some information. This is authorization in effect from the date this form is signed until a written notification to revoke. And you put your address down here, that guarantees that we're going to, well, I say that guarantee loosely.
Possible, right?
Yeah, guarantees. The worker should put your address in there and be sending you information as an authorized rep. And so they go into the contacts, they put you in as authorized representative to receive all notification of changes and such. But again, they've got to sign that and go through that. But that's a really good just question on how do we make sure we get authorized on a case with DWS. This is the #1 way to do it.
Great.
Any questions on 114?
Is there a way to get all that DWS mail via email instead of postal mail?
Oh, you ask such good questions. No.
I was going to say, currently, no. Currently, authorized reps only can get it through the post office.
Okay.
You may have a really nice caseworker that will email you notice of decisions and those things, but you'd have to really butter them up, you know, send them a Christmas gift. I don't know. I'm just
I was going to say, aren't state employees prohibited from accepting?
Yeah.
So maybe that's not the best idea.
Under $50. Under $50.
Oh, under $50. All right.
Nate, this is Blake. On that 114 and with EREP, is it feasible that there be more than one representative listed, so there could be a family member that gets the review notice as well as the CMA?
Oh,
Case
yeah.
management agent? Oh, okay.
If you'd like to list 2 or 3 people on there to be authorized, and they say, I want to authorize these people specifically, and their addresses are on there, we do it.
All right, thank you.
That sounds like the solution then. As good as it can get. Okay, great. Thanks, Nate. All right, this looks like an interesting question. We have been told by DWS caseworkers that DWS is recommending clients stay on New Choices waiver long-term and not be transferred to nursing home Medicaid even after their 90 days in the SNF. We have been told that the reason for this is that after the COVID period ends, they will have to reapply as well as for other reasons. Should we be closing them out for New Choices waiver? And I think you're shaking your head no, Nate, but from our position, our guidance was, yes, we should be closing them out. So if there is a communication issue between the agencies, we can work on that separately. But I guess just to confirm that the guidance is not different.
You are correct. This is ugly. This is a really ugly, and I'm aware that this is probably being told by workers or telling New Choices people this, but this is not a correct thing to be, you know, this is not how DWS is doing business.
Okay, so we'll work together then to get the information shared that disenrollments should be processed. Okay.
You are correct.
Can you speak to the part of that question that asks if they'll have to reapply? I'm not sure if they were talking about reapply just for new choices waiver, which they would, and that's not a problem, but there's no reapplication process or on the Medicaid eligibility side, which we've already established. There would be an asset review, but proactively that should be followed up on. If it's not, no action will be taken. So,
You are correct.
okay. All right. I think we've covered all of the bases there. Let's see. There's a question that just popped up that may be related. Okay, so I thought that the Appendix K was why they were not transitioned to nursing home Medicaid in early guidance. You're correct. This is a bit of a situation where we have some whiplash happening, right? Where we had guidance early on that said we will keep them open. That was our understanding based on the information provided at the federal level. We got clarification, and now a different strategy is occurring. So, you know, we're kind of all in the same boat with this one, realizing that there's a different way to handle this, and now we all respond in the same way and go, all right, let's do this. So thanks for being patient with that. So Tracy, you're right. We did say something different a while ago, and now the guidance is updated. Any other questions on the DWS or Medicaid eligibility policy side? I'll give you a few more minutes to put in your last minute questions in the chat before we let these guys go. We are so grateful you were able to come today. This has been a really great discussion. I was worried that the most we would be able to offer was, let me get back to you with that question. And that would not be as satisfying as the conversation that's been had today. So thank you so much.
I was prepared to say that, though, Lainey. Like, we'll get information to you to pass along.
I know that's kind of a default state employee answer, but I'm really proud of us that we have these answers. You know, we're doing the best we can here. Certainly we don't know everything, but we're doing our best to figure it out. So, all right.
I'm confident in the decisions we've made, or the statements that we've made are very, you know, consistent with what we've been doing and what we want to do going forward. So we do know that this is going to, like Jeff has said, to unwind this thing is going to be as ugly or twice as ugly as it was getting into it. And possibly this year is what it looks like it's going to happen. So just know that we are just so willing to work with you, talk with you. I know that the DWS teams are really willing to communicate and just say, this is what we're seeing. And really, if they have concerns, they're going to push it up to Jeff and I to Jeff, most likely. And but that's our commitment. We really want to make things work for you guys and just keep it going.
Thanks for that support, Nate. I know a while back. Oh, go ahead, Jeff.
Oh, sorry, I didn't mean to interrupt. All I was going to say is, as you were just talking about, the guidance given months ago is different than guidance today. The information we're getting from the feds changes every week or two across pretty much all programs, and it's a moving target. And until we unwind, which your guess is as good as anybody's, most rumors are it will go the whole of this year as well, and all we'll know ahead of time is we'll get 60 days notice before it's going to end. But between now and then, acceptable guidance still could change. They might once again change what we can and cannot do on a case while the health emergency continues.
Yeah, that is very true. We went through a period of time where we were wishing that we could go back to the days of, this is how it is, it does not change. We are rigid state policymakers, and that is that. I know that that's the perception in the community, and then we had to be so flexible and nimble for quite a while that we were just craving that normalcy. So I think we'll get there. We will all work together to find the solutions to these questions as they come up and navigate it. So back to your point, Nate, on responsiveness from the long-term care team. Before all of this started, I actually got contact information for all of the eligibility workers, and it was parsed out by the area that they were assigned. I think it was by county, if I remember correctly. So maybe I'll get with you all on the back end and see if that's something that can be shared to our case management agencies, if you're comfortable with that still. That might facilitate some communication. So we'll connect about that afterward, if that's okay. Okay. All right. So it doesn't look like any more questions have come in for Nate and Jeff and Alan. So if you want to stick around, you're welcome to. But if you have other things you need to get to this morning, we can let you go back to your day. So thank you so much for joining. We really appreciate your help.
Thank you all. It's so good to see you. You have a wonderful day and party on.
Thanks, Nate. You too.
Yeah.
Bye. All right, so let's kind of segue more into the Appendix K provider guide questions. First up are the questions that you guys submitted in advance. And this question is, what is the process of reporting COVID via the tracking sheet, not the incident report? So this is a pretty good example of guidance whiplash, right? We've had to adjust as new things happened, new procedures happened. Initially, the guidance was created when we had 500 cases a day, and then when we were at thousands of cases a day, we had to adjust because that meant a lot of incident reports for you guys. So currently, we would like to have you guys note positive cases and then some follow-up information on the COVID tracking spreadsheet and submit that weekly to ncwincidents@utah.gov. And the follow-up information that should be included is the date of the positive test, the name of the facility they're living at. We would like to know whether the individual was hospitalized, with morbid, but also if they have passed away. And if not, we would like to know the changes resulting from the positive test and actions in response to those changes. So at a minimum, we're looking for whether or not there was a change in living setting and any changes to the care plan. This exercise becomes an element of capturing information because we, as the state Medicaid agency, are required to demonstrate that we are protecting the health and welfare of our participants. And we trust that you guys are doing all of this, and we just need to capture the information. So that is why we are asking for these items. And then kind of as a second set of eyes, we're to make sure that health and welfare is protected. So any more questions about that, please just submit them in the chat. Next question. Can we extend a care plan on a client through 2020 that was a direct ALF admit when the paperwork was done in April 2020 telephonically? So I'm guessing, well, let's just back up and go over the care plan extension versus when an assessment is needed. So we started extending care plans, I believe, in March or April of last year. And at most, a care plan can span 24 months. So if you're trying to decide whether or not you can extend a care plan or if an assessment needs to reoccur, if the care plan already spans 24 months, a new assessment needs to take place. If it does not span 24 months, you can extend it. I hope that clears up any confusion. So we're circling back now to the time where a care plan for a new enrollee could have been created based on a telehealth assessment. And now it's the next review period, and you're wondering whether you can extend the care plan based on a telehealth assessment completed. And the answer is yes. You could still extend the care plan if it doesn't exceed 24 months, regardless of whether the assessment was done in person or by telehealth. Okay, next question has to do with the disenrollment process. Does a new DPF-1 need to be submitted? For example, if a DPF-1 was submitted in April 2020, is that sufficient? So maybe not the friendliest of answers, but yes, we do need you guys to submit new DPF-1s because the dates have changed. And as you can see, there's a lot of moving parts in a disenrollment between you and us and DWS. And for the sake of clarity, we need updated disenrollment dates on those documents. So a follow-up question to that I've seen is, what should the disenrollment date be? Should it be the 90th day or the 91st day of the SNF stay, or should it be after January? And let's determine a date that's after January. The way that DWS closures work, it's usually the end of the month. If it's within 10 days of the end of the month, then it will be the end of the month of the following month. So just note disenrollment as of the end of the month that you are submitting it, and we will go from there. Hope that answers that question. So yes, submit a new DPF-1 and then update the care plan to close. So in another guidance, Whiplash, we previously issued guidance that said to keep care plans open and end all services, all waiver services, but just list nursing home. We're no longer going to be doing that. So that's off the table. You can disregard, and procedures will resume where we are disenrolling individuals for being in a nursing home for 90 days or more. DPF-1 should be submitted and the care plan should close. So yay, we do a happy dance that something is normal like it was before. All right, next question. Let's see, you're welcome for the clarification. Next question is, we are running into situations where we would like the flexibility to meet with facility staff, like a nurse or an administrator in person. Is this allowable since it is not direct client contact? So this is kind of tricky. The updated guidance that allowed for in-person visits when telehealth is not feasible and when there is no other alternative to meet an individual's need was not made lightly. As you know, we've been very conservative with protecting the vulnerable population that we serve and disallowed in-person visits. We've heard whisperings that that still continued under the radar. We've always had kind of assumed positive regard for our provider groups and put a lot of trust into our providers that best practice recommendation will be followed. So in no way do we want this to be something that opens up a pathway for in-person visits all the time, because there is a teeny bit of an allowance. The vaccine distribution rollout is going well. We're making great strides there, but we're not at the end. So we still want to be conservative and protect vulnerable individuals. However, it's been a year, and we still need to balance the need to protect individuals from exposure with the very real need that exists to ensure health and safety and ensure quality service delivery and services that are going to meet individuals' needs. So if there is no other alternative but to go into the facility and have this face-to-face meeting, because it's an issue of health and safety, then yes, that can occur. But if it is marketing, networking, casual hellos, things of that nature, that's still disallowed. I know that there's concern expressed that this has not been communicated to the assisted living facilities, and so there is pressure being put on you all to go in. And, you know, as private businesses, I can respect that that's on your radar of wanting to maintain those relationships. So we will be working on some guidance that will go out to the assisted livings to support the messaging that we are giving you, so that you have support from us as you're communicating with these providers, so they understand the requirements that you are trying to comply with, and in an effort to maintain your business relationships. So we understand that that's an element at play, but first and foremost, we still need to protect the individuals we're serving. Okay, next question. Can we have more clarity on the expectation for having a New Choices Waiver medication review form on file for every client for 2020? Most of our clients had extended care plans, so we did not do an MDSHC in 2020. Were we still supposed to complete a New Choices medication review form? Let's see. Annie, I'll come back to your comment. I think that's a really good one that we should address. So the medication management review form. The timing of the implementation of this and COVID kind of coincided at the same time. So there's been a lot of confusion. I think we have an acknowledgement of that. And while we are working to bring everybody on board with the expectations, we're also figuring out how we navigate this from a procedure standpoint. So if medication review forms were not completed in 2020, there's not an expectation that you go back and backdate them. Please reach out to us and we will figure out a path going forward that is compliant with the expectations. But also with everything on our plates, we'll cut you a little bit of slack if that did not occur. But let's clarify the expectations going forward so that we're all on the same page. So the medication management review should be conducted quarterly from the date of the most recent. So if you're working on an extended care plan, you will have 7 quarterly reviews off of an MDSHC that was completed at the very beginning. So for example, the last MDHC was conducted on January 19, 2021. The next review would be due April 19, 2021. CMAs may conduct the review within 30 days of the review date. That is 30 days before or 30 days after. You have a window there because we know that doctors' offices don't always respond as promptly as we would hope. They have a lot going on as well. This is the time frame that is given that RNs can anticipate that it may take to complete the review. In the previous example, where the last MDSHC was conducted on January 19th, 2021, the form can be completed between the window of time, the 30 days before and after. So that window looks like March 19th through May 18th of 2021. The next review should be due quarterly thereafter. So essentially, you have 60 days to complete a quarterly review. Okay. The dates of the medication management reviews are not based on the care plan date. The reviews are only based on the date of the most recent MDSHC. With the extension of care plans, we realized that some limitations on the form exist where they only go to quarter 3, but you may use a new form for quarters 4 through 7. And we will just recognize that in our reviews. That will be okay. If there is a change in level of care prompting a new MDSHC, then a new schedule would be created based on this new date. With this in mind, there would never be an occurrence where a medication review would lapse over 90 days. So this information was pre-populated by Marisol. We definitely appreciate you, Marisol. So if I stated anything incorrectly, please chime in. It looks like on this same topic, we had another question come up. On the medication management review forms, do we need to save all of the medication lists and MAR reports that go along with those for the year? Will they be needed for audit? There can be a lot of pages to those med list and MAR reports. So technically anything can be reviewed for an audit. So yes, I would say you need to save those. They're supporting your work. And there will be more discussions that come with what we're going to do with these med review forms. We're still very much in the stage of completing them to check a box. And eventually we will move towards completing them and looking at the value that they're adding. In the beginning, we talked about having another work group to reconvene about how the form is working, what questions exist, and how we can follow up on that. And we intend to do that, just COVID got put in the forefront of everyone's mind. So keep up with those. We appreciate the work that you're doing and all of the great questions, because we can tell that you guys really are concerned with being compliant and meeting expectations, and we appreciate your efforts to do so. Okay, so going back to what we were talking about in-person visits. Comment was, different agencies follow this guidance differently. That puts pressure on all other agencies who are following your guidance. And I agree with that statement. This is where truly we need everyone's cooperation to be a united front here. We don't have eyes and ears in the field to monitor every interaction. So there is a level of trust that we have in you all, and we very much are relying on that. So it's not okay that we're not all consistent, and we need to be. So that's why we will be issuing this guidance for the assisted living providers, so that they understand, and hopefully that will take the pressure off of those individuals who are going in. Recognizing now, though, that there is room for independent discretion and assessment of the situation that may not be able to be addressed in any other way besides an in-person assessment. We have had those situations come up where there is an immediate health and safety concern, and that has required an in-person visit. That will be communicated to the assisted living facilities as well. We understand that they're responding with, pretty significant statements that imply that you aren't doing your jobs. And we know that that's not the case, and we'll support you in these efforts. And we would just appreciate those who are following this guidance and hope that we can be consistent as a group. If you have questions about what's an appropriate situation to in versus stay out of a facility, you can always reach out to us and staff that. I understand that on the other side of that coin are agencies who, for staff have concerns about going into facilities for personal reasons, where they are at a higher risk of complications due to COVID exposure. And so there are concerns on that side as well. This is not just for the sake of the vulnerable individuals that we serve, it's also for the sake of the healthcare providers in that setting. It's for the sake of you all, because we're all connected. And nothing exists in a vacuum, and this is one of those. Let's see, some facilities are allowing attendant providers to come into the building and take the client out. Is this allowable now? That is a question that I will have to ask health facility licensing. I will be honest and say that the instruction to the assisted living facilities when there are outbreaks is not always being communicated to my office. Parts of state agencies don't have that intimate of a relationship because of the nature of what we do. So there are times where I've reached out to the other entities in the Department of Health and Epidemiology to verify practices that are occurring that seemed odd to us in the beginning. You know, especially where it surrounded people leaving the facility and then getting evicted. That happened a lot as well. So I will reach out to health facility licensing and see if that's allowable from our perspective. New Choices Waiver, unless I'm incorrect, I don't believe we disallowed attendant care providers from going into the facilities to remove people or remove them, take them out into the community on an outing, simply because that was a practice that was implemented by another part of Department of Health. So if that's coming up now, we will address it. And thanks for making that an action item for me, Amelia, I appreciate it. Related to in-person visit, the previous question, can you clarify if essential is not regular but a needed contact, not monthly or ongoing? So if I'm understanding this question correctly, we're wondering where the line is between what deems an essential in-person visit versus just a regular monthly contact visit. And those are all going to be case-by-case scenarios. The scenarios that have come to light so far that we feel have warranted an in-person visit are concerns of staffing at the assisted living facility, where through a telephone conversation, the participant tells their case manager that they're not getting their medications, that staff are not available, that all staff have COVID and no one is there providing cares. That's a pretty extreme example. Another situation that came up was a facility moving a participant into memory care, and there were significant rights concerns based on the individual's diagnoses. And it was determined that memory care was not appropriate. And only after an in-person assessment occurred, because at that point, completing it through telehealth was not possible due to this individual's disabilities. So that would warrant an in-person assessment. Again, that's tied to an immediate health and safety risk. I imagine that there could also be extreme examples where an in-person assessment or in-person visit is needed for socialization. You know, I'm sure you guys are getting those phone calls by people who are just so depressed and begging for a visit because they just need to talk to someone. That should not be the impetus for in-person visits to occur on a monthly basis. But I think as social workers, you guys all have this, and nurses, you all have the skills to know when someone is in crisis versus when you can provide that reassurance over the phone. So I know that doesn't answer the question in black and white terms. We will have to use our best judgment, and knowing where we are coming from, hopefully we've communicated our position clearly enough that that makes that easy to navigate. But we are willing to staff these cases with you if you have questions. All right, next question. Regarding the previous medication management review question, for clarification, can we use the MDSHC done previously that was extended to do the 7 med management reviews? Oh, there's the answer. Thanks for highlighting that. You will note the most recent MDSHC on the form. This includes extended care plans for quarters 4, 5, 6, and 7. So yes, you can use the MDSHC that was done a year ago that you're not redoing to complete quarters 4, 5, 6, and 7. All right, we're running close to time, so I will try and get through these questions as much as I can. We have a few more left, so we'll see how far we can get, but we also do have part 2 next week, I think. The 4th, that should be next week, yes. All right, what will be the changes made to open enrollment for direct AL admits? When will it go back to pre-COVID enrollment windows? So there are 2 parts to this question. You heard earlier that states will be given a 60-day advance notice of when the public health emergency ends. And we have also received recent guidance that states will have 6 months from the end of the federally declared public health emergency to transition off of Appendix K policy. So where the current emergency declaration goes through April, we have 6 months from April at the earliest in which Appendix K policy will end. That's assuming that the declaration won't be extended, but it has been extended every quarter since the beginning. So who knows what will happen there, but we have a really good length of time to make these transitions. The second part to this question is in the waiver renewal that occurred in July of 2020, part of that process included a back and forth exchange with CMS, where for whatever reason, their guidance from when the AL enrollment process was created changed. So in the renewal, the state has committed to serving up to a point in time number of participants during the year. And that number is 1,925. So when regular policy becomes effective, we will admit individuals who meet eligibility criteria until the point in time service limits have been met. Applications for waiver slots will be evaluated in the order in which they were received, and it will be a first come, first served basis. So it will not look too much different than what's occurring now. There will no longer be the 3 open application periods. It will be first come, first serve, and slots will be filled as individuals from qualifying settings apply and are determined eligible. We're still working through what it would look like if that point in time limit of 1,925 is met. I can't make any promises on what will happen there, but since New Choices Waiver is a cost savings program. It's financially advantageous to work with CMS to increase the point in time limits. Since it would cost the state more money to serve people in nursing homes. So while I don't know what it looks like, I can tell you that there probably wouldn't be interest in creating a wait list, although anything is possible. So we will have more information as time goes on about what that would look like. That is definitely an item that we will be working through in anticipation of the 6-month transition off of Appendix K, but the main takeaway is the open application periods will not be applicable.
You need a towel or something? What's the matter? Well, I can get you something.
Sounds like maybe that's not a question for us. Okay.
Take that in the house.
Let's see. I got that one. Okay. So it looks like that was our last question. We captured all the other questions as we ran through the list of items. So we've got 10 minutes left. I don't know if there are any last minute burning questions or any thoughts about what was covered. I think we can open it now to unmute if there's anything you'd like to chime in about what was already discussed, or last minute questions. No? All right. So just as a heads up for next time, after today, there's been a lot of information. We've used our time really well. So upcoming next week, send us more questions that come as a result of this meeting. But we also have some more guidance to present as far as the price approval process that was noted in the provider manual at the end of last year. We will be going over the technical guidance and some new document revisions that were made for that. We also would like to do a medication management review form work group to hear from you guys how that's going. I know that initially there were concerns about how this would look in practice, RN's activities, and I'd like to revisit that and hear how that's going. And we will also go over updates made to the state implementation plan with last year's renewal. We haven't had a chance to go over that because of COVID. Everything just coincided at the same time. So now hopefully things are a little bit more stable and we can take a breath and revisit that. So you guys all have an understanding of what changed. The updated state implementation plan will be available on our website shortly. So for those who are policy language oriented, you can soon find that on our website. So since these meetings are taking the place of our annual CMA training, we will need to capture attendance. We used to do that on a sign-in sheet. We will be sending out a Google form link. And if we could put that link in the chat right now, that would be helpful as well. Please help us out and complete that form so that when it comes time to reporting our performance measures up to CMS, we can show that we are compliant with our requirement of providing training to our case management agency groups. Let's see, one last question that came in. Any guidance on porch/outside visits 6 feet apart this spring and summer if the case manager is vaccinated? Clients are asking this a lot. I think this is a great question, and we'll be prepared to answer it next time. I think summer is exciting. A lot of people will be vaccinated by summer, and our guidance about in-person visits and what's acceptable will likely change as new information comes out as far as the efficacy of the vaccines and when all of these precautions can be lifted, what needs to occur in order for that to happen, herd immunity, all the things. We just don't have enough information right now to know how to answer that question. But we will do some more research and discussion at this point to see if we have anything we can garner from the information we do have, but I anticipate the answer might be we don't know yet, and we'll have to see. But great question. If you have any more of those types of questions of, what will change at the point when everyone is vaccinated, or what will change in the summer relating to X, Y, and Z, let us know, because you guys are the ones that think through the logistics. We try and do that, but we don't catch everything because we don't do it as frequently as you do. The experts of how things work in the field, and we just try to create policy that will make that a little bit easier for you all. So that was a lot of information. We appreciate your time. Thank you for joining us today. Some great interaction, great questions, and we look forward to seeing you all back here next week. Let me make sure I'm saying that correctly. Yes, next week, March 4th, same time, 10 a.m. All right, everybody, good luck. Have a good rest of your day. Talk to you later. Bye.